Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before we get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. My first guests today are from Cognishine, a company that is based in Israel and is doing some really innovative work around supporting virtual therapy. They've got this personalized technology that uses cognitive, speech, and social emotional interventions, specifically as it relates to virtual remote management, and specifically that support of that for therapists. We talked to George and Arie from that company, who are leaders in both product development and commercialization. And they talk about some of the lessons they've learned building this technology and implementing it in Israel, and how they're thinking about applying it as they bring it to Europe and North America. So tell me all about Cognishine and how it got started and what problem you're looking to solve.
Okay, so Omkar, we are Cognishine. We are an Israeli startup company. We have a digital therapy platform for allied health therapists. It's focused on the intervention, so on the actual therapy sessions that the therapist will do with their patients, one-to-one in groups, teletherapy, asynchronous, so in all kinds of different forms. We are used mainly by occupational therapists, speech language pathologists, and psychologists. But generally, we are going to be growing to really cover all of the main allied health therapy professions. We are an Israeli startup, but we are already quite established. We have 4 subsidiaries. One of them is in the US. We are present in 10 countries, 5 continents, and we are expanding more and more. We have more than 100 hospitals as customers, more than 5,000 therapists. And what we do is we digitalize the standard of care that these therapists are using. Now, we currently have about 5,000 of those activities, but the truth is this is going to grow exponentially because we are going to start growing also using more and more AI to really broaden and expand all of this.
So Arie, tell me more about why a solution like Cognishine would be valuable in a place like Israel.
Let me just start with how did we start with Cognishine. Actually, when we was looking during COVID time for synchronous and asynchronous solutions, for therapy, we thought about what can we do remote, what can we do between sessions, and I didn't do, but we are a pediatric rehabilitation hospital, so we are focused on the same kind of therapy that the George or the Cognishine delivers. So when we started to investigate what kind of solutions are available in the market, we found Cognishine. We met them on one of the Zoom calls during the beginning of COVID. And what we saw is that they are addressing a major unmet need of us for synchronous and asynchronous therapy. So our therapists can work in a person and at home with the patient. That is a key for us, for our ability to deliver our service anytime, anywhere. Let me give you an example from the current situation. Current situation in Israel, some of the patients cannot come to the hospital. Patients that are day hospitalization or need to get therapy during times that they are afraid to go on the road. And with Cognishine, what we can deliver is remote sessions. We can assess, we can give them obviously, again, asynchronous exercises, and we can assess their progress. So it's just a great system that gives us a solution for what we need, and it's what we need in many fields. So it's not only in occupational therapy, we use them for SLPs and so on and so far.
That's great. And I can imagine the value of having both the live synchronous telemedicine as well, or teletherapy, along with all the asynchronous work that happens as well. You were mentioning that your future holds, or perhaps even the present holds, the inclusion of artificial intelligence and data and other technology to even optimize what you're doing in the current state. Walk me through what that looks like.
So one of the key things that we always try to keep in mind, also when we work with artificial intelligence, is the fact that we want to make sure we really include the therapists into the whole thinking. So the AI needs to support what the therapists want to do with their patients. So to give you an example, we are currently just started up, and it's going to be live very soon, is a kind of a game store where using AI, therapists can exactly define what they are looking for, what types of an activity. Is it for articulation? Is it for cognition? Is it for concentration? Give exactly the kind of area and focus, and the AI will basically create the activity or the game for them. And we can then, and that's the nice thing, is take this and then integrate it into the platform, using it, saving it, keeping it organized, putting it into organizing it into boards which everybody, all therapists can use, sending it to the patients. So using the AI to really make the life of the therapist easier. And that's one area. Of course, analytics is going to be a key thing. What's going to be a key area is, like, building a session with AI. So the AI will help the therapists, give them the recommendations based on the situation of the patient and the availability of the activities that we have, the right kind of sequence of activities that work ideally for the patient, and so on and so on. But everything keeping in mind that we want to support the therapist, not replace the therapist.
Just one comment, or not
Go
comment,
ahead.
just to add to, if I may add to what George says, we saw when we were part of the discussion around the new features with AI, I think that the new level of personalization of therapy, you can personalize the session, the therapy session, to the exact need of that specific patient and with that specific therapist. And that's easily to be done and very intuitive. So that just brings another level of personalization.
What has the reaction been from parents and kids? Is this being adopted at the rate that you're looking for?
So what we see is, I mean, one of the things that we cover, a wide range of patient groups, and children and adolescents are, of course, a key part of it. Now, what we can do, what we add generally, therapists who always control what's going on are using the kind of activities that are really tailored to the kids. So we have specific content. We're using, of course, lots of cartoon and gamification and things like this to make it specifically relevant, especially for the kids. And we know that, of course, the fact that kids generally like to be surrounded by digital tools, they love the tablets, they love the mobile phones. Our platform can be used on all devices, including on mobile phones. So generally, we're seeing very, very good uptake amongst both the therapists, the kids, and of course the family as well. Because one thing that you also have to remember is that, yeah, maybe kids are spending a lot of time on their devices, but if they're doing something sensible, something that's really helpful for the therapeutic goals, then also the parents are very happy about it. So we are very, very pleased about that.
George and Arie, thank you so much for joining me and talking on our podcast about the great innovation of Cognishine. Next, we talked to Dr. Rohit Kohli. Dr. Rohit Kohli and I have known each other for many years. He's the chief of GI, gastroenterology, hepatology, and nutrition, a leader in liver disease, and just a great person that I've gotten to know for many years here at CHLA. He talks about mentorship, and he's always talked about this on some of his social media platforms. And so we dug into it in this interview, and I think you'll appreciate his perspective on the importance of how we're going to teach and mentor the next generation of clinicians across the country. So enjoy this interview with Dr. Kohli. Dr. Kohli, thank you for joining us.
Oh, this is great. Thanks, Omkar, for having me on.
We've talked about academics in pediatrics and the importance of it, as well as some challenges facing us as we think about the next generation of academicians in pediatrics. What is your take? I mean, you personally come from a long trajectory of somebody who has built a career in this space of academics in pediatrics.
No, this is very, very close to my heart. You're right. I've spent the past 2.5 decades investing time and effort first initially in learning how to be a pediatric academician and then trying to be a successful one, garnering
You've been very successful.
external external validation, funding, and now I think more giving back to make sure that our future in academic pediatrics is secure, the pipeline is robust, investing time in that. So yes, in the past 3 decades or so, definitely have been through those 3 phases of my life, if you would want to call it that. With the cherry on top, at least that's what she tells me. Our oldest daughter wants to go into pediatrics as well. So
That is a
she's
cherry on top. I mean, nice reflection of what you do. So, just from the historic standpoint, how do they start building, or how have they historically built a career in academics and peds?
we in the United States have been actually very much protective of that population through various support mechanisms, including institutional, societal, foundational, but primarily the National Institutes of Health really have bolstered the development of academic physicians in general and pediatricians, specifically what we're talking about today. So when you're in training, finish medical school, there will be pathways wherein you can take time off for research through pediatric scientist development program mechanisms, grant mechanisms. When you get to the subspecialty phase of training as a pediatric subspecialist, the American Board of Pediatrics wants you to spend a solid 2/3 approximately of your training time period at developing a academic product. Again, providing the milieu, so to speak, to breed, to foster the academic pediatricians of the future. The amount of time and effort that therefore our society has afforded has borne fruit. We have a tremendous capacity to generate new knowledge, innovation, new device development, pharmaceutical development, implementation of these innovative technologies through quality improvement methodologies. All of that comes from the workforce that is now trained because of these protective mechanisms. Then a subset of these individuals who finish their training will continue to have quote unquote fire in their belly and be the force that perpetuates, mentors, and gives direction to the field as leaders in academics.
And I've seen and heard you talk about the importance of mentorship. How has it helped you, and how are you helping others as you think about mentoring in the space of pediatrics?
It's really critical to receive and to give mentorship. And not just mentorship, and you know this, Omkar, it's also about coaching through the tough spots. It's also about sponsorship when you're not with your mentee in the room, but you still speak about them in the best possible light so that they get the value and the opportunities that they deserve at the fora that you have a seat at the table for. My best experiences have been through receiving mentorship. I still remember my first initial break was totally serendipitous. I walked into as a young first year subspecialty trainee to my division chief's office door. I wasn't even in his office. And I said, "Hey, Peter," his name was Peter Whittington. And I said, "Peter, I'm coming up to my second and third year where I'm going to do my academic work. Can I work in your lab?" And he says, "Sure, happy to have you. What do you want to work on?" And I say, "Well, X, Y, and Z. I've been thinking about that. It's really interesting, and I've done some preliminary work in that." And he says, "Yeah, but the fellow of the year ahead of you, he's working on that. I don't want you guys to compete. Why don't you work on fatty liver disease?" And that 30-second conversation, Omkar, believe you me, has transitioned me into the last 3 decades of working on liver disease. So
Wow.
it's really important, these individuals who can see behind the curve or beyond the curve across the hill, and they have that vision that they can share with you. And today, I want to be that kind of person for people who walk into my office doorway, hopefully giving them some sane advice.
Since you helped and dedicated so many people with those few words of encouragement that you got so long ago. It's amazing. So as you look ahead, what gives you optimism, but also perhaps some concern as you think about academics in pediatrics for the next generation?
Well, optimism for sure. As we mentioned, seeing these young people, including one at home, who want to serve and give back to the field of pediatrics in general and academic pediatrics in particular. Well, there are some headwinds for sure. Our healthcare system as a whole is going through a lot of financial pressures. We evaluating how we structure and pay for the things that are our mission across the board. The American Board of Pediatrics has just released a couple of weeks ago a new announcement thinking about how we frame subspecialty training. It's up open for public comment, but that might be important to that protection that I early on talked about for developing researchers and academicians of the future. How we preserve, I was just at the Pediatric Academic Society's meeting, and how we preserve this cohort of leaders, developing leaders into the future where they will continue to push the envelope and continue to innovate and make the lives of children better. We can't do that without people having the time to think, the resources to do, and the fire in the belly, as I said, to deliver new knowledge, so that the entire community of pediatrics can then take that on and use those better tools and thought processes and workflows to improve care for children everywhere. So I feel that there are financial pressures. I feel that there are time pressures. But if our North Star remains the same, which is to focus on the child and the care of the child, I think we will always have the ability to force forward. I'm an eternal optimist, as you can see.
You are, and I appreciate all your posts on LinkedIn about little things you can do to remind us about how to be future focused and excited about what's around us. Are you seeing any shifts in the makeup of the new grads coming out of school? Are you seeing any differences inherently around kind of, generational differences between the people coming out of school today?
Yeah, you're talking about when I had to draw my own overhead projector slides. Let's not go there. Half the audience probably doesn't even know what I'm talking about when I say OHPs. But yes, we've come a long way, and today it's all about artificial intelligence and innovation in the computing powers that we have now are at our fingertips. That's the part that excites me, is that we can elevate everyone's ability to be part of the conversation in terms of innovation and advances in academics and science. Because now individuals that are graduating now, their palette is so much broader. Even as a fully trained pediatrician who wants to contribute to the field, you could do it through quality improvement science, implementation science, basic science, translational research, clinical research. The amount of arenas that are open today were not open to me when I was starting off. It was much more traditional. Let's go to the wet bench and look at molecular pathways, because that was the question of the hour, the need of the hour. Today, there is so much knowledge we already have that bringing that knowledge to the bedside, to the clinic, to the patient. I always remember I went kicking and screaming into QI school when I was given my first leadership opportunity, came as a package deal. And I came out drinking the Kool-Aid, because even if we produce the best pill for the largest and most onerous disease that our populations face, if the individual patient does not take that pill, all of that is wasted. So bringing that not only to the prescription pad, but also to the adherence of the population at need, that is a science in of itself. So I see, to your question, when we have new technologies that allow us that extra 10 minutes per half day, we could be contributing even through our clinical work to a small QI project that is inbuilt into our EMR and able to elevate the care of our patients.
Dr. Coley, thank you so much for joining us and sharing your words of optimism as we think about the next generation of academics in pediatrics.
And so always a pleasure, Omkar. Thank you so much for having me.
Finally, we talked to Kenzie Davis. Kenzie is the founder and CEO of a company called Maro. They're a digital health startup that is in a really important space, in my opinion. They are getting into the world of supporting school districts as they screen students for mental health. First, they're helping screen these kids for potential mental health issues, which is important because screening in the schools allows us to capture a large chunk of the pediatric population. And then they're connecting those kids that need help with resources. And so it's a really unmet need, and I'm excited for this conversation because it highlights a gap that exists in our world, and Kenzie and others out there are looking to solve it. So hope you'll enjoy this interview with Kenzie Davis. Kenzie, thank you for joining us.
Happy to be here.
So I want to start with a couple recent policy announcements that have come out the last couple of years, and would love for you to explain to me and to our audience kind of what they are and why they're important as we think about mental health for kids. So we'll start in Illinois, where they passed, I believe, what they call SB Senate Bill 1560. And that's a really big deal in terms of mental health screening. So tell us more about what that is and why it's so important.
So Illinois has done something that is really innovative. They spent quite a bit of time doing a landscape scan, talking with schools and communities to understand readiness, preparedness for universal mental health screening in schools. And they have figured out kind of what is needed in order to do that well and at scale. And essentially, what they're doing is in the same way that we've now made it really routine to do physical health exams at school, your vision, your hearing tests, they're adding mental health to that list and incorporating resources around it. So once students are screened, what kind of support is available. So they, in 27-28 school year, they'll be officially phase 3 rollout of the universal mental health screening policy for all kids grades 3 through 12.
And then in California, there's the Child and Youth Behavioral Health Initiative, CHBHI. Talk to us more about that. It's a little different, but I think it's designed, again, to help schools better tackle mental health screening and mental health resources they need.
Yeah, so this is really interesting because California has taken the approach of basically fiscal sustainability. How do we ensure that schools can get reimbursed the same way that providers in any other setting would for the work that they're providing to students at schools, and make these mental health care programs more sustainable? So providers in schools can now get reimbursed for therapy that they're providing in school, for screening that they're providing in school, for all kinds of case management services they're providing. It's really exciting, and they've been doing kind of the groundwork to roll that out over the last couple of years.
So we hear about this growing almost epidemic of mental health in kids and adolescents. Clearly, these states are taking the lead and coming up with innovative policy approaches towards tackling the problem. But from your lens, describe the problem. How big is it, and how problematic is it that it's going unsolved?
So one of the statistics that made this so real for me, because you hear a lot of stats, 1 in 5 kids have a mental health disorder. A lot of that is undiagnosed. Even more of it is left untreated. But the problem is so big, it's almost hard to grapple with. So for me, the thing that we really orient our mission around is this average 11-year gap between first symptom and treatment. And that's kind of the root of the problem that we solve. So this is data from 220 children's hospitals across the nation that have compiled their research and come up with this average 11-year gap. And basically, that's just to say the need's not being identified early enough. They're not getting care fast enough. And thus, we end up with a lot of kids who ultimately are at a point of crisis by the time that they get support.
So I think the way to think about it is there's a child that has a symptom, and on average, it takes about 11 years for that child to actually get the treatment they need to solve that mental health issue that was first presented, almost a decade earlier.
That's exactly right. And my only problem with this framing is it's very binary. It just says basically symptom treatment.
Right.
And something that's important, I think, to understand is when you have kids who are presenting symptoms early, you don't always have to get them into clinical treatment. At that point, it's sometimes as simple as just a trusted adult in their life realizing that something's going on and opening the door to conversation and just making sure that they feel like they have someone that they can talk to. And that's a
Yeah.
really simple framing where it actually can make that big of a difference that that child, doesn't end up needing treatment down the road. I think that word sounds a bit scary
So the
for
first
people.
step in this is screening. We don't have enough tools and processes and infrastructure across our country to help screen kids for mental health. And so that's where Maro comes in. Tell us more about what you built.
So we built this tool that it's the most robust universal mental health screening platform in the country, but it makes it really easy for schools to conduct mental health screening and get kids to the right level of support. A screening program is only as good as the interventions that you pair with it. And part of the approach that we have taken is really analyzing the supply demand. April Coe, founder of Spring Health, actually talked about this really recently with Milken Institute. And she talks about how, yes, there is a provider shortage, but actually a big part of the problem is that we just aren't matching the supply with the demand. And that's part of the problem that we've been solving with our technology is we understand the demand through screening and we're matching the supply with that where we're actually reducing pressure on community organizations that have very lengthy wait lists and we're bringing virtual care around the table and helping them unlock a referral channel that they don't have access to usually.
So there's two problems you're solving. One is you're helping schools screen kids across the country, sometimes because they're required to, like in these two states, and often because there's just a need. And so that's one problem. The other problem you're unlocking is there are providers who do have capacity to provide mental health services and treatment. They're just not being connected efficiently to the people who need those services. And so you're helping create both solutions for both these problems that kind of reflect both the supply side and the demand side.
That's exactly right.
What makes your screening solution so unique? I imagine it's a bunch of questions that are digitally administered, but it's got to be more sophisticated than that. How do you create a special offering that is distinct?
So part of it is we've taken best practice from manual screening processes and we've taken all the administrative work associated with that and all of the compliance work and we've created a digital process that solves for the things that are quite time consuming. Some of the number one things that we solve for first, our platform is agnostic to survey tools. So a lot of organizations have entered the space and they've created their own screening tool. But the challenge with that is it doesn't scale when you go from school system to health system because providers then have to rescreen that child with clinically validated tools. And so part of what we've done is we've made it work with any clinically validated tool.
So, uh, child screens positive in the Maro tool. It's the same questions perhaps that their local hospital or provider would have asked anyway. And so you don't have to rescreen them. That data can then be used almost seamlessly by that provider who now understands better just how acute or severe or urgent their need is.
Exactly. And they may elect to rescreen a child anyway in a different setting, but you don't have to because we're using a consistent measurement tool.
Okay. What else? So that's one great unlock. What else do you have?
The other thing is the policy differs based on where you're at in terms of how you collect consents and communicate with parents. So we've taken both the technical approach of being able to adapt to different regulation in different states, and also a very cognizant approach of the cultures and the people that we're interacting with, where we work intimately with the school to understand, how can we educate families on the value of this, but also respect parental rights. It's your option whether or not you want your child to be screened at school, and we want to make that abundantly clear. Also give you, transparently, this is the survey tool your school is using, and these are the types of questions that are going to be asked. And so that consent process from start to finish, parent communication, parent education, is something that we've spent a lot of time perfecting.
And then are there analytics at the school level?
Oh, absolutely. You can even see, across students who have been screened multiple times, including looking at your aggregate school district, even county data. You can see what the improvement and decline rates have looked like. And we're actually working on being able to tie that correlation to intervention. So we do a lot of documentation. That's where we save schools a lot of time and create capacity, is in that follow-up documentation. And so that's something that we're looking at right now.
So far, of the screeners you've administered, approximately what percentage are coming back positive?
The challenge with that question is it depends on the sensitivity of the screener.
Okay.
So, we have tools that are more sensitive. They're screening for depression, suicide, and we've developed even custom flagging systems to help. This child likely has a plan and a means based on their response, versus this child has some ideation but isn't in dire need of services in this moment. And so for the more sensitive screeners, you could see up to 25% of your kids have some level of suicidal ideation. But I would say for, some of the others, we're seeing closer to anywhere from 10 to 20%, depending on the environment that we're screening in.
And I imagine many of these kids perhaps were not screened ever before. And so these may be net new diagnoses, or at least could lead to net new diagnoses.
Yeah, that's right. They certainly could lead to that. The big thing for us that's been really interesting that I didn't quite expect is students really want to respond to these questions. I just had a school tell me 2 days ago that some of her students said, "My mom said that I can't take this, but I really feel like I need to talk to somebody," after they learned what kinds of questions they, would be asked if they had consent to take the screener. So that's been a really interesting observation, and students really feel like this is a secure, safe way where if I don't have the language or I don't feel comfortable verbally communicating this with someone, I can tell them how I'm feeling in a digital environment, and they're going to help me get resources.
I could also imagine that beyond self-harm, this could perhaps over time help schools identify kids who may look to harm others through school, some sort of violence in the school, and perhaps could create an opportunity for earlier detection.
I believe that. Yes.
Are there models of other countries that have done this already or screened students or kids for mental health where we could learn from?
Yeah, there's some really compelling studies. There's one I could point you to out of Australia that has done some really good work in early screening and pairing that with intervention. I'd be happy to share
That's
as a
really
follow-up.
interesting.
Yeah.
So what's next? You've got Illinois, California, which I imagine are really highly motivated to drive this, because I believe there's some funding as well as available for these from these schools, right? What's the funding opportunity that's available to support this type of screening?
Yeah, so Illinois is going to procure a tool. What we're doing right now is we're offering Maro completely free to schools. Go ahead and adopt ahead of the mandate. If you want to run a small pilot before rolling out universal screening, that's actually best practice and something that we can help you with. We're working really closely with schools in Illinois to support them leading into the mandate. And then in California, we're actually rolling out CYBHI billing documentation in our school. One of the challenges that we hear from schools that are rolling out billing is a lot of school based providers haven't had to do billing and documentation in the past. And so it's a new skill set that they're learning. And so we've created the easiest entry point for schools doing CYBHI billing, because with screening, we already have all of the documentation that is needed to submit those claims. So a school based provider can just hit submit, and we're processing all of that for them. 100% of the funds go back to the school.
Kenzie, thank you so much for joining us today and telling us about all the great things you're doing with Maro.
Thank you so much.
All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.